Hi, I'm Dr. Javed Butler. I'm a cardiologist and a clinical trialist with Baylor Scott White Health in Dallas and professor of medicine at University of Mississippi. And today I will talk to you about the pooled analysis between the Victoria and the Victor trial, which was presented here in the late-breaking clinical trial session at ESC 2025. We know that the Victoria trial showed a couple of years ago that patients with heart failure with reduced ejection fraction and a recent worsening heart failure event, which was described as either hospitalization for heart failure within the past 6 months or need for outpatient IV diuretic within the past 3 months. In those patients, the use of Vericiguat was associated with improvement in cardiovascular death or heart failure hospitalization. Victor trial was done to look at now the rest of the spectrum of HFrEF patients, that is, those patients without worsening heart failure, ambulatory patients. Those results were also presented, and this particular pre-specified pooled analysis was to look at the entire spectrum of heart failure by combining the Victor and the Victoria databases together. This was a pre-specified individual patient-level pooled analysis of the two studies, where we combined first the entire spectrum of patients with the entire severity of the disease state, but then also we learned in the Victoria trial that people with higher NT-proBNP had less benefit. That actually informed the design of the Victor trial that included patients with NT-proBNP of only less than 6,000. So we also then did focus analysis of those patients in the combined database with NT-proBNP of less than 6,000. And in the two groups of patients, the entire population and those with NT-proBNP less than 6,000, we looked at 4 outcomes. We looked at cardiovascular death, all-cause mortality, cardiovascular death or heart failure hospitalization, and heart failure hospitalization by itself. The key findings for the results were that if you look at the entire study population, there was a statistically significant benefit on all 4 outcomes of approximately 10% relative risk reduction. When we narrow into the population of those with NT-proBNP less than 6,000, again, we found statistically significant benefit, but the benefit was even stronger in that group, ranging from 5 to 17% relative reduction in that particular group. The key take-home messages are that 1, in this combined pooled analysis of all patients across the entire spectrum of disease, there was a statistically significant reduction in cardiovascular death, all-cause death, cardiovascular death or heart failure hospitalization, or first heart failure hospitalization, all 4 outcomes. All of them were statistically significantly reduced, and the benefits were even more so in those with NT-proBNP of less than 6,000. Combining this with the known safety and tolerability profile of Vericiguat, we now have yet another therapy to improve outcomes for our patients with HFrEF. The next step, like all things, you have a positive result from any given trial on an outcome, is the implementation. Because the implementation in the real world, there's a lot of inertia. And I think these patients are at a very high risk. So now moving away from evidence generation to evidence implementation, and how quickly can we get the patients who deserve these therapies. And I'm not talking about just one Vericiguat, I'm talking about all heart failure therapies because there's a lot of inertia. I think that's our real challenge now.